Case study of interstitial lung disease, aka ILD, and here are the contents of the document along with the page numbers every content is on. Interstitial lung disease case presentation. A 35-year-old male with a history of smoking presents to his primary care physician with a several-month history of progressive shortness of breath and a persistent dry cough. He reports that he has been feeling fatigued and has lost weight recently. He has been working in a construction site for over a year. History: former smoker for 3 years. Symptoms started 2 months ago and got worse over time. Recently lost 5 kg weight. Past medical history: he has diabetes mellitus and hepatitis C. Family history: grandfather had lung cancer. Occupational history: working in construction site near a coal mine. Assessment, examination and inspection shows cyanosis, shortness of breath, clubbing of nails. Palpation shows reduced chest expansion and it is bilateral. Auscultation shows fine crackles on both sides during inspiration and wheezing. Percussion shows dullness over the apex of the lungs. Diagnostic tests: chest X-ray shows diffuse retinolondular opacities. HRCT, that is high resolution computed tomography, confirms the diagnosis of interstitial lung disease. It is also gold standard test for ILD. Lung biopsy to examine a small sample of lung tissue for signs of ILD. Bronchoscopic for fluid evaluation. Therapeutic tests: PFTs, that is pulmonary functional test done through spirometer. 6 MWT, that is 6-minute walk test to endurance and cardiopulmonary tolerance. Differential diagnosis. Differential diagnosis for interstitial lung diseases can be following: bronchiectasis, idiopathic pulmonary fibrosis, obliterative bronchiolitis. Medication: corticosteroids, prednisone, antifibrotic and cytotoxic drugs, pirfenidone, cyclophosphamide, cytoxin, mycophenolate, that is Cellcept. Treatment: conservative management, pulmonary rehabilitation, management of breathlessness. Advice on passively fixing the shoulder girdle for optimizing ventilatory muscle efficiency and relief of breathlessness. Forward lean sitting, high side sitting, standing with back support. Intermittent positive pressure breathing, that is tidal volume must be increased to achieve a therapeutic effect. For this purpose, CPAP can be used. Respiratory muscle training: inspiratory muscles should be trained in order to maximize the breathing effect and minimize discomfort. Pursed lip breathing training helps get more oxygen into your lungs and calms you down so you can better control your breath. Exercise training of the muscles of the ambulation. Oxygen therapy: short-term ambulatory oxygen used to keep up the oxygen level in blood normal when doing exertion or some kind of activity which in other case would result in dyspnea. Supplemental oxygen used to increase exercise capacity. Psychosocial care: depression and anxiety, recommend leisure activities like music, yoga and meditation. Counseling: administer into counseling sessions and boost up the confidence. Social interaction: try to induce the socially connected and communicative environment around the patient. Education, self-management and support: educate the patient about the seriousness and complications of the disease. Teach self-management skills so that he can work or exercise normally when alone. Video lectures: sharing lecture and guides in the video format helps the patient. Community-based rehab: there are 2 types of goals: short-term goals and long-term goals. Short-term goals: reduce shortness of breath, minimize fatigue, reduce workload over respiratory muscles, prevent weight loss. Long-term goals: prevent deformities, prevent further scarring of the lung tissues, prevent chronic cough, adopt palliative care, overcome the limitations, and improve quality of life. Prognosis. Patient followed the protocol and performed accordingly, following the guidelines and instructions, thus reducing the risk of progressing toward the chronic conditions. Physical therapy for at least 6 months was performed, center-based, and 1-year home-based plan is devised as well. If all the protocols and measures are met, patient has good prognosis. In chronic conditions, life expectancy is 3 to 5 years after diagnosis. Home plan. This home plan is devised specifically for this patient with ILD, exercise training for 3 times in a day for 6 months. The level of exercise will advance as time passes by from beginner to medium to moderate. Warm-up protocol. Simple, gentle movement to get your muscles, joint and heart ready for activity. Number 2, it allows your body to gradually adjust to doing more work and prevents straining muscles. Number 3, can be done standing or sitting depending on how you are feeling that day. Number 4, warm-up should be 3 to 5 minutes or longer if needed. Exercise protocol. Number 1, maintain good body posture and position whether you are seated or standing. Number 2, pace yourself. Find the right speed and rhythm that works for you. Number 3, breathe regularly during strength exercises. Exhale as you lift the weight and inhale as you lower it. If you are doing leg lifts, exhale as you lift your leg and inhale as you lower it. Number 4, avoid straight arms and gripping tightly. Keep arms slightly bent and comfortable grip. Number 5, use smooth controlled movements with lifting. Number 6, to prevent injury, avoid jerking or thrusting. Number 7, stop the exercise if you are experiencing any joint pain during the movement. Number 8, avoid holding your breath and straining. Cool down protocol. Just like the warm-up, the cool down should be slower and gentler. Slow down the speed and or reduce the workload. Allows your heart rate, breathing rates and blood pressure to return to your baseline normal gradually. Patient discharge. After keeping up with the patient for the set time, that is 6 months, and confirming if he needs any further assistance, the patient was discharged from rehab to resume his normal life. No ambulatory or physical aid was required at the time of discharge. Patient feedback. Patient was satisfied with the therapies he got. Pulmonary rehab pretty much restored the strength and tolerance, and shortness of breath was also lowered to bearable extent. Patient observed low fatigue as well as the weight was gained. Patient approved of the treatment and agreed to come again if necessary and also recommended to others. And here are the references.